Can everyone see the slides? I'm going to go with, brilliant. Thank you, Tom, for asking me to speak about CKD in Sheffield, and it's nice to see so many familiar faces around. And a shout out to Lucy, if you're hiding. I've just met somebody I went to med school with 20 years ago and haven't seen. And apparently I just found out she works with Kate. So I'm like, there we are. So anyway, that's background. So I won't bore you too much. You don't need to know too much about me. I'm a GP partner in Steel City General Practice. I'm also GP Training Program Director. For the GP trainees in the room, there's 3 QI projects out of this, so pay attention, and then you can get it all done very, very quickly. I'm also one of the officers of the LMC, so there's 5 of us, so I'm 20% of the officer team of the Sheffield LMC. So if you like what we've negotiated, I did it. If you don't, it's the remaining 4, who I don't think are in the room. No, they're not in the room. So yeah, if it's good, it's me. And unlike other speakers you've had today and the ones who's going to come on, I am not an expert in CKD at all. I am a jobbing GP, and I like every single clinical aspect I do in general practice, and I probably do all of them equally badly. So I don't profess any extra knowledge that I can part with you, but I can certainly share with you our experiences of working on CKD over the last few years, and how that informed the local contracts that the LMC negotiated on your behalf. And now anybody can just literally offer me a beer or dinner and I'll go speak to them about CKD and diabetes. That's literally how cheap I am. Now, why CKD? We looked at, when it comes to local negotiations about quality contract or anything else, we don't just decide based on our individual interests or what we think will work. So there has to be a process of understanding what the local priorities for Sheffield would be and how do we go about trying to prioritize something in there when you've got limited funding and not that much provision and capacity in general practice to really push something to the boundaries. So we decided on CKDs, and I'll talk you through why in a second, as to the priorities for us locally, in discussion with our local commissioners, would be to focus on prevention. Again, not a huge deal that we can do in certain situations, but subtle changes perhaps we can make in day-to-day practice. And detection and coding was just, there's a few of my fellow IT-friendly folks in the room. There's Jess is there, so Liam Lee. So a few of us are in the sort of Sheffield IT group where we geek out on coding and templates and protocols, which most of you would find boring. That's absolutely fine. But when we talk about the coding, particularly with CKD, in most of general practice, not just in Sheffield, we're not that good at it because it is very complex and unnecessarily complex, which we can actually look to simplify. Why does that become an issue? We'll talk to you about that slowly too. And also about monitoring. Some of you will remember how CKD indicators changed in QOF over the last decade or so, as more and more indicators started disappearing from QOF, and now CKD is completely gone from QOF. Monitoring not unexpectedly, has declined over the last decade or so, particularly with urine ACRs, which I don't think we've put enough emphasis on. So that's another area I wanted to focus on too. And there's been some experiences already in Sheffield over the last couple of years about working in conjunction with secondary care. Nephrologists are very keen to work with general practice to try and intervene at CKD at an early stage so that you can stop the progression to the more later stages, which it wouldn't surprise any of you. Hazard a guess how many people die of CKD? Very few. But CKD increases your risk of cardiovascular disease, which is what eventually leads to somebody's demise rather than people dying with CKD. So, now, one of the questions we had when we discussed this earlier on, pre-negotiation phase, was can we really aim to be excellent in treating chronic kidney disease in primary care? The answer is I don't think, looking at the resources and the capacity we have anywhere in general practice, I don't think we can aim to be excellent in anything at all. For most of us, I suspect you're trying to get through one day at a time and then get back to work the next day. That would be a win. But this isn't about making it 100% fixable, but it's about making that little bit of improvement and starting off from where you're at and then building on to the next stage. No, have I broken it? No. So, I don't know if you're familiar with COD Prevent or not, so let's start with here. I'll take you through the Sheffield data. If you want to scan that QR code, if you've got a smartphone, don't feel obliged you have to. If you do, Nat, can you switch over to the it'll take you to the CVD Prevent data. Now, if your practice haven't shared the data, you may not find any information on there, so don't worry about it. You can choose to look at your own practice data or your network data or Sheffield data or national data. It just gives you some information about the indicator. So go on to the indicators if you're on there, and then when it does load up, it'll give you, sorry? Oh, sorry, yeah, 1 second. Nat, can we go back to the, it's loading up, okay, internet's not that great. Okay, if we go back to the QR code again, so if you scan that, if it takes you to CVD Prevent, just leave that on there. Oops, sorry, Nat, go back out it again. You clicked. Or you can just Google CVD Prevent, that'll take you to the same page. Sorry. Yeah, but just Google CVD Prevent. It takes you to there, and on the Explorer, type in your practice name. It gives you the data. Now, can we go back to this slide deck? And on there, you can pick the CKD indicators. It will tell you what the data for your practice is. Now, any piece of data that you look at, you've got to take it with a pinch of salt. It does not mean in absolute terms this is the problem you have to fix. It gives you a set of numbers that you can start working from in terms of how much potential CKD you have in your practice that you can look at diagnosing and coding appropriately. And if you look at Sheffield, our prevalence for CKD, and again, that's the 4 places within South Yorkshire, so we're not that bad. Now, what's the true prevalence of CKD in the country? Depending on who you speak to, you're going to get a slightly different answer. 6% is the one that's quoted. Those of you who've done the exercise of actually case finding and identifying those patients and coding them may find that the real number is a little bit higher than that, and in some cases twice as high as that. That would naturally mean there will be some practices with either younger populations or atypical populations where you're likely to have less prevalence than the 6% that's quoted at you. So don't look at 6% as the one to aim for or to move away from. That's just the number that's quoted. So for us in Sheffield, so we are second of the 4 places in terms of the prevalence, which is there or thereabouts, but certainly not the 6% that's nationally projected. And some of you will recognize over the last few years, there has been a metric and quality contract about case finding CKD. So these are patients who have had EGFRs less than 60 or an ACR that's abnormal, but who haven't been coded as CKD. So that's anywhere from G3A to 5. 5 becomes less important, not clinically, because one would hope if someone's got CKD5, they're already under the nephrologist and there's very little that we need to do in general practice, which is true, but certainly the groups 3 and 4 that's progressing. And I would probably hazard a guess that most of you, certainly like we used to, for us, the treatment of EGFR is active observing. So you look at the graph, and then you keep looking, and then you keep looking until that happens, and then you panic, and then you say you need to refer. So that's the treatment for CKD, yes? Yes. That's what we would do. That's what we have done for a long period of time. But certainly from your efforts over the last 2-3 years, where there's been a support from Sheffield Place to, we actually have less of undiagnosed CKD compared to the other 3 places in South Yorkshire. That's something for, as a collective, for all of us to feel incredibly proud about, but there is still some more work to do, which is where the rest of the things come in from. Okay. I've broken it again. Okay. So this one is the one where you're looking at, so the previous one is the 2 EGFRs and ACR. This one is the people who have had 1 EGFR that's less than 60, but who do not have a GP recorded CKD. All of these patients do not have CKD. So the implication here is not find them all and put a CKD code in their notes at all. Some of them will be acute kidney injury, where you've seen something and sent them to hospital, and then they've been either treated, they've been seen, and the subsequent EGFRs are completely normal. They do not have CKD. But unfortunately, like they have in Rotherham, where you can just click a button on ICE and it downloads the particular blood result from ICE into your GP systems, we don't have that functionality in Sheffield. And there are lots and lots of different excuses. In fact, Ngosi's colleague, Andrew McGinty, has been working with them for God knows how long. I had hair when he started the discussion with them, and SDH are still finding reasons of why that can't be done. But if we just switch across to M1 in Rotherham, that's been there. When I did have hair, I was a trainee in Rotherham nearly 2 decades, not 2 decades, but 15 years ago, and they had that functionality there. So some of this is made difficult for Sheffield General Practice because the IT systems just aren't up to scratch to be able to support us with that. So these groups of patients do not all have CKD. All you would need to do is to just look through their records and look at if there's a ICE reading on the EGFR that's raised, and that's come back to normal after a drop of 60. That's fine. That's all you need to do in the records. You don't need to do a great deal else beyond that. But which we then move on to diagnosis-wise, those are the two main areas you need to look at, so EGFRs and ACRs. But when we look at monitoring, we're very good at doing U&Es for people with known CKD in their records, because that's how you monitor it, right? So most of them will get at least once a year. Some of them, if they're significantly lower, then they will get it probably more than once a year. So we're well above 90%. In fact, most of the country is well above 90%. So we're not bad at monitoring EGFRs. We are bad at monitoring urine ACRs. That's around 50%, hovering around 50%. And again, certainly, trainees in the room, hands up, how many of you are around? Yeah. Oh yeah, wow, there's lots of you. Okay, cool. They got the spiel already. So when we talk about measuring and monitoring kidney function, simple, kidney's a filter. You want the good stuff in, bad stuff out. So you can only measure the bad stuff, i.e. creatinine, proxy for bad renal function in the bloods. But if you don't measure the amount of protein that's being excreted in the urine, you're only measuring half of kidney function and not the whole kidney function. But I think urine ACRs are a little bit more difficult to do because patients will come in, I'm out to take the blood sample. Can you produce a urine sample? I've just been for a wee. I can't, I'll take the container away, and they don't come back. I'm not asking you to follow this, but we certainly moved in a direction of the practice where if you have an U&E, you're going to have an ACR. Right. So there may be certain situations where you don't need to do that, and there's certain situations where you shouldn't do that. If someone's got a catheter in, or someone's got an acute infection, or somebody's menstruating, or recent acute problems, so on and so forth. But the default is, if you're measuring kidney function, whatever the circumstances it is, you can't just do half of it. So GFRs have to go with urine ACRs, was the other one that we thought. You can't do it for everybody, but certainly we can do better than what it has been done before. And if you project this graph backwards to nearly a decade, we were actually doing about 70–80% of urine ACRs at that time. But slowly the CKD metrics have dropped, and this happens for everything that disappears from QOF. Some of it is nonsense from QOF and that needs to disappear. Some of it is valuable chronic disease metrics that once it disappears from the QOF indicators, it just so happens we stopped doing it. That's what happens. They're called INLICs if you ever want to look at the data indicators, no longer in QOF. And by all means, you can look through that information there. And the last one is the treatment data for people with CKD, and particularly getting them on to RAS therapy in the first instance, and then rapidly moving on to SGLT2 inhibitors as a second line once you optimize them on RAS. Again, there's always the risk when we talk about it. This is not simply about adding more and more medicines to people. A lot of CKD patients are very frail, elderly, significant comorbidities, or potassium that's already on the higher ends of normal, and certainly you don't want to be adding them more medications that's going to make their hyperkalemia worse. But at the moment, looking at data, we're not quite where we would want us to be with respect to treatment with the appropriate medications for CKD. I think the phase of active observation as treatment of CKD is probably finished, and we probably need to make that transition into just not looking at the graphs, but doing something about it, which first line now is RAS therapy for that one. Oh, am I going the other way? Oh yeah, last one is about the blood pressure thresholds again. For most hypertension indicators, when you look at it, for whether it's blood pressure monitoring for people in strokes and TIAs, or people in coronary heart disease, or checking everybody's blood pressure once in every 5 years as per the normal blood pressure indicator, all the other hypertension indicators, we're reasonably well and mostly across Sheffield. But when you look at people who don't fit into those groups but have CKD, and we talk about hypertension monitoring, again, there's probably room for improvement. So this is a set of data that informed the discussions between Sheffield Place and the LMC when we were negotiating the local quality contract. But this year, we took a different approach to what we do normally every year. Every year, any ICB colleagues here or Sheffield Place? Brilliant. I can make fun of you in your absence. That's fine. Yeah. No, actually, it was a very collaborative discussion. So it was no longer about frantically at the end of the year trying to put something in place very quickly and not necessarily thought through. But we took it to the LMC in August of last year to say, what do we actually want to see in the local contracts? And not surprisingly, when we talked about the quality contract, the first thing the LMC member said is, we want it to be about quality. So it's not just about doing more and more and more of something, but make the focus about quality. And we want the funding and metrics to be discussed and agreed with the LMC. Because again, we will disagree with commissioners. That's part of the LMC's job, where if we feel that it's not appropriate for general practice to do something if we don't have the capacity or if we're not funded properly. It doesn't mean we fall out over it, but let's have a constructive discussion where we can actually build something over a sustained period of time that will support general practice. So that was one of the principles. We wanted to make sure that the quality improvement aspect of it is acknowledged, that there are two facets to it. If you want something to go from A to a higher point of B, that requires support. Some of it may be support in terms of workforce, some of it may be support in terms of funding, some of it may be something else, technology, it could be that. But once you get there, if you withdraw the funding, it will drop. That journey of going up requires funding, but maintaining there also requires funding, otherwise it will drop. QOF indicators, the withdrawn QOF indicators, is the classic example. You've got data now going back at least a decade and a half that shows what happens when support is removed for certain indicators. We wanted to make sure that it remains voluntary for practices. So if you don't agree with a particular indicator, certainly feedback to us, feedback to the PCD team and Sheffield Place, but it must remain voluntary, so nobody should be pressured into taking on any of the quality contract metrics if you don't think it's right for you. And then we went on, it said payment should be for individual metrics, so we didn't want you must do all of these and hit the targets, otherwise you get nothing. That doesn't work. General practice isn't that kind of homogeneous place where we can all aim to aspire to the same standard across every single metric there is. We have different populations, they have different needs. We'll succeed in some and we won't in some, and we just have to acknowledge that. I won't read all of those, but there are the basic underlying principles that we as a committee agreed to use in discussions for negotiations with the quality contract. And that's where we ended up with 3 different metrics. 2 in the local quality contract, which is about improving the quality of both diagnosis and monitoring. And the third one is about the medications, which is the RAS therapy in there. So the local plan was to address the coding issues and try and get closer to the true prevalence of CKD. You will not get it to 100%. Some patients will simply be lost to follow-up. You can go to their homes with a urine sample container and say P. They may not be there. You still won't get it. But it's also about improving monitoring, but not just from an EGFR point of view, but also getting the importance of urine ACRs and explaining to the patients why it's important to have both those tests done. And I work on the principle that if someone has a bladder, they've got urine. So literally that's all you'd need, ideally a container. That's it for urine ACR. But like I said, there are certain caveats where you can't do it and it'll become less accurate. So we'd always dip the urine, make sure there's no blood in there, because if you've got hematuria microscopic and then you send it off, it'll come as a falsely raised ACR, and then you inadvertently diagnose somebody's CKD based on that one. So if they've got blood, you automatically move them to the microscopic hematuria pathway in your surgery. If they don't have blood, send it off. Comes back normal, absolutely fine. You fixed it. You don't need to do anything else. And optimizing management, there's that fine balance between how much do you push medicines versus lifestyle changes versus overprescription. I think one of the talks earlier on, we talked about that in terms of more and more medicines and the anticholinergic burden of all of those kind of things. Fortunately, not many you use for management of CKD have this anticholinergic effect. But if you don't really want an 80-year-old and 25 different medicines just because the metric says so. So you need to be able to shift away from those vulnerable patients and not just add more medications. But we also wanted, part of the quality contract wasn't just a new set of metrics every year. We recognized that CKD is probably one of the more chronic conditions with large numbers that has no funding at all in the GP contract. If people tell you yes, ARRS, all these kind of things, ignore all that. There are no disease-specific funding metrics for CKD, full stop. The only one we have is the local contract. So we wanted to build on the principles of actually let's improve on detection, let's improve on monitoring, let's then improve on treatments. So whether it's ACE inhibitors next year, eventually SGLT2 inhibitors, there's a natural progression of people who need to be optimized to a point where once you get to that stage, you will actually see an improvement in outcomes. And certainly we did a bit of work with Arif Khawaja, who's the consultant nephrologist. Is Arif around by any chance? No, he got the invitation. And then in just space of 12 months, you'll see significant changes in what CKD management does to your patients. Because CKD isn't just about treating their ACR and EGFR. You're looking at their lipids, you're looking at their blood pressure, you're looking at their other reversible risk factors that you can have an influence on. And it does transform how one would approach it. So the intention is we start off on this year. There's already the third version of the searches that you need to look at, because we get feedback from you to say, actually, this bit doesn't work, or can you tweak this, and so on and so forth. And we will. So if there's aspects of it that you think doesn't quite fit, let us know. We'll continue to tweak those. So in terms of the metrics-wise, so we discussed and agreed on these three metrics. I'll show you where the searches are for EMIS and System 1 practices. I'm just hazarding a guess nobody else is in this room who doesn't use EMIS or System 1 in their GP practice, right? Good, because that would be a surprise. So the indicators are, the first one is the first two in the quality contract are about people who don't have the diagnosis of CKD, but their biochemistry indicates that they may have CKD. So all you're looking at is going through the searches and see how many of these patients have diagnosis, which seems actually that is CKD, we just haven't put the code in. Just put the code in, that's it. The second one is again about the monitoring. How many of them had annual EGFR and urine ACR? Some of them, it is difficult. I'm not going to stand here and say to you, you'll hit 80, 90, 100% targets. You'll not. Getting urine from people is still difficult. Getting them in for blood tests is still difficult. This is a journey. Start off, see how it works for you, and what the particular challenges are, and both the commissioners and the LMC will need your feedback to try and tweak, learn from these as we go to inform the subsequent years, rather than a rigid, there's the line, thou shalt hit this or not approach. So that's what we did with this one. And the PQUIS indicator, which I've also included in here, is obviously not in the quality contract, but we were conscious of the fact that we didn't want mission creep of more and more indicators. If it's a prescribing metric, we want it in the prescribing quality incentive scheme, so stick it in there. So that's about getting people on RASes, and all the searches are within both System 1 and EMIS Web for you to look at. So for System 1, it is in the guidance all your practice managers would have got. They're now on version 3. Those are the searches that you'll see. Ignore all the Z searches. So it's a number starting from 1 to 2. Not all of them are things that you need to add. Some will tell you the bit that you've already done. Some will tell you the bit that you need to work to do. And the searches are self-explanatory on there to go through the numbers. Again, for EMIS practices, the searches have been built and are within EMIS 2 for you to look at the size of that. So when you look at the CVD prevent data, and if you think your numbers look too big, just to be conscious of the fact that that was March 25's, that quarter ends data, so that it will look slightly different now, because some of you would have already started some work on it. And there may be, again, if you talk to people around the room with interest in coding and particularly CKD, there are 100 different ways of skinning this cat. There are lots and lots of searches on. There are some from Ardens. There are some from CDRC that if you use that, which is the set of searches that were developed by Northeast Commissioning Services in Durham, and lots of different ways you can look at it. But these are the ones that we've agreed locally to work with to say, look, these are the ones we think are the most reasonable way of approaching it. If your numbers look too big and you need some help with this, don't worry, there is a plan. We'll come to that. So that one, that's updated CKD guidance, by the way. If you haven't seen it, it's just been updated in the last few months. If you just take a picture of that, that will take you to that one, which has been developed by Diana. Diana, you around? Man, no one turned up to the Sunday invite to. That's okay. She did all the work, but I'm here to take the credit for it. So it was developed with nephrologists in the hospital. Again, it's very primary care focused, and it is supposed to be a supportive narrative rather than, again, lots of different boxes for you to tick. But what have we learned about CKD so far is, like I just said, it's not just about the EGFR. And it's got to be, you're taking an approach when you're managing CKD of actually managing CVD of that particular patient or groups of patients. It's about their lipid management, optimizing their cholesterol. It's about making sure that the blood pressure and things and comorbidities are dealt with as best as you can based on your population characteristics. And with urine ACRs, which, as I said before, just keep it simple. If you're doing an EGFR, do an ACR. And most of them are normal. But it's surprising how many we picked up that have a completely normal EGFR and just persistently raised ACRs repeatedly. So that's a whole group of CKD we just don't diagnose if we just do EGFRs. And it's interesting, you'll take slightly different approaches. Liam Knight, is Liam in, guys, today? So Liam's one of my colleagues in the practice. So Liam and I did a piece of work on CKD and went to present it at the Grand Round at SCH. And it's surprising, when we talk about nephrotoxic drugs, pretty much every single one of us in the room will say, yeah, NSAIDs, obviously, there's things we want to get rid of. Do you want to hazard a guess which is the medication that nephrologists are worried about, that we prescribe a lot, and we never check their kidney function? Any volunteers? PPIs, there you are, that's it. The volume of people that we prescribe PPIs to, and if they're just on a PPI and they don't have any symptoms, I wouldn't bring them in for a uni. But that's what they're noticing. It's no longer the NSAIDs, because it's been drilled into us over the last couple of decades, so you don't just perpetually leave people on NSAIDs and not monitor their use needs at all. But the volume of people we're putting on PPIs that don't get taken off because it works for them, they're symptom-free, just let them be. And not to mention the anticholinergic burden. I mean, it's only a score of 1 for PPIs, but it's still an anticholinergic burden that comes from medicines. So that was the feedback we got from nephrology. It's not about NSAIDs, it's not about the DMARDs and other stuff that are very, very small volumes, but we do monitor them regularly. It's the ones we put on medication and leave them be and never check because they don't have any other comorbidities. And the next time you check it when they hit 40 or 50, that's where the kidney function is. So PPIs, so de-prescribing that element of it. Yeah, and the last couple of points on there was about don't take the approach of we're just doing the CKD management. It's about the CRM approach, which is the cardiac, renal, metabolic medicine, and they're not individual conditions. The pathophysiology of all of that is exactly the same. Treat all of them together, but come from a CKD angle than otherwise. I pause there. How am I doing for time? 5 minutes. Brilliant. Perfect. And so Diana has done the CKD guidance. That's the previous slide if you've got. The local contract metrics, if you need any further information on that, Sarah Bentley is the person. I'll circulate the email address at the end of these with the slides. So she's one of the primary care development nurses, absolutely amazing to work with. She knows her way around the searches. And if you've got feedback on what you've done so far and you want to feed that through to Sarah, you can do. Boehringer are also supporting us with 3 educational events. So they're complementary. It's not one of those 3. So if you want to scan that, QR code. See, I'm losing it. So QR code. Those are 3 workshops. Sort of going into more in depth about how you actually start coding these CKDs and what are the exceptions and how you approach it. The second one is about then optimizing the treatment, but going into a little bit more detail, getting secondary care consultants to come and talk to us about the kind of things that they see from us and how they can support us. And the last one is sort of reflecting on the change and how the change management approach in your practice has gone. And then hopefully that will give us some learning that can be passed down to our colleagues in Sheffield. So those 3 events, or all 3 of them, by all means, please click the QR code and register with it, and you'll get more support through that. The person who's not here, I think Lauren Fensom isn't here. So if you see, is she here? Lauren's not here. So Lauren will talk you through on the coding aspects of it. I feel she's my philosophical twin, so I've not met anybody as fascinated with coding as I have with Lauren. And she's written the most amazing guide about coding. And I realize there's probably only me in the room that's getting excited about this. That's fine. I'm happy to be the geek. That's okay. But in terms of most people, we don't have the time to do it in that much detail. But Lauren will take you through it, and she makes it look so simple in terms of the approach to take, rather than what feels like most of you would be, where the hell do you start? I've got this many patients. So she'll be there along with all those workshops too. So I'll pause there. Like I said, I'm not the clinical expert in CKD at all. In fact, Lucy will remember, I think we did those jobs together, didn't we, Lucy? 2005 in Renal in York Hospital was the last time I did anything remotely to do with kidneys. But what we have done over the last year and a half is to approach CKD differently than we had done before, and that has been positive. And I think this here to stay. I suspect at some point it'll become a national contact metric again, subject to how discussions go nationally. But there's a lot we can do beforehand. Pause there. Thank you. Oh, hi there. Sorry.
Two really quick things. One is just to remember that we don't always prescribe the non-steroidals. So I saw a chap last week with new CKD.
Over the counter.
And
Yep.
he's taking ibuprofen for his headaches.
Yep.
So the other is the urine ACRs. Do they need to be an early morning urine? Or what happens if it's not an early morning urine?
Okay. Do you want the official answer or a practical answer? Practical answer, okay. So not everybody can have the urine ACRs first thing in the morning. So we just say, look, if you're coming in, we'd like you to come in with a bladder full, make sure you drink plenty of water the day before, and when you're having your kidney function done, drop off your urine sample. If the first one comes back abnormal, subtly abnormal, so 3 to 30 range, that's when you say, okay, that one's abnormal, but the second one definitely needs to be an early morning sample, and make sure you do not do anything that increases the level of protein in your urine, including intercourse. I mean, obviously there's other obvious ones, like don't take a urine ACR from a pregnant woman because that'll be raised and so on and so forth. So the first one is try and get away with, because most of them are normal, but where it's abnormal, make sure you're more stringent with the second one so that you know if it's real or not. So I think it's a pragmatic approach. The official response is yes, early morning sample, full bladder, and none of these things in the past. So anything?
So you mentioned briefly patients with normal GFRs but abnormal ACRs. We've had a few of these come through. Just wondered how we should be managing them.
So if, again, subject to the levels of the proteinuria, so if it's between the 3 to 30 range and then the G1 and 2, it is active monitoring to some degree too. But you've got to take it on the individual patient. So if there's a significant increase in urine ACR and you're worried about it, does everyone use the Ardens templates in practice? Both EMIS and System 1, as far as I'm aware. EMIS also has the same. It has the referral criteria of when you should refer to nephrology directly from it. It's got about 12 different points. One of them is about the KFRE score and all of those things. So if in doubt, by all means, get through to nephrology to say, this 21-year-old with a completely normal eGFR has a persistent raised urine ACR of 30, and the team gets back to you very, very quickly. But in terms of treatment, unless it's a significant proteinuria, if GFR is more than 60, you're not really looking at pharmacological treatment as such, but you still do the lifestyle things about a healthier, less salty diet, weight, comorbidities, and so on and so forth. Anything else? Oh, so it's letting that home.
So the metrics in the quality project,
Sure.
they're very similar to QOF, but as QOF was in previous years.
Yes.
With QOF, it was very easy to exempt patients.
Yep.
How easy is it to exempt them in the quality project?
So at the moment, how do I answer this? So when you talk about exempting them, I suppose you're talking about how do you get them off that list, those searches that appear to you. If there is a subsequent eGFR or a urine ACR that's been done in the hospital that's completely normal, all you need to do is put that number in and put the right date on, and it disappears off that list. So because they no longer have a raised eGFR or a urine ACR without subsequent diagnosis, it's come back down. The other bit I think has been the one that's slightly contentious at the moment is that the current position is that there are QOF exception rules for CKD monitoring, which I think some colleagues have expressed some concern about, because if we do that, that removes them completely from the CKD indicator for monitoring, which is absolutely true, but there is no monitoring for CKD in anywhere at the moment. So you're removing it from something that doesn't actually exist.
Because I'm really thinking about frail elderly people.
Yes, yeah.
You don't want on an
absolutely. So in that scenario, I mean, what I certainly would do is just put in, say, ACE and ARB not indicated. So same thing with SGLT2s. So for us, we built some searches which automatically pull certain people out. If you're over 85, palliative care or moderate to severe frailty, so let's not over-medicate these people at all. So they're out. It's the rest that you want to focus on. Yeah, yeah. And normally in the next box next to it, I just say frailty. I'm not putting them on any meds, full stop. And that's it. So, oh, sorry, more.
Obviously, you've done a lot of.
Oh, sorry.
Into this. I'm just wondering what you've adopted in your practice from a coding point of view, so to ensure that you're coding appropriately, but you're also not missing any follow-up. So, say for example.
Sorry, let me go back onto it.
Yep.
Yep.
The GFR comes back as a CKD3, but you haven't got ACR results. What are you doing in terms of coding at that point?
Okay, so in terms of any new EGFR that, I mean, we have our own rule set for pathology processing, and it's not just about the kidney function, it covers all sorts of other things too with the new auto review functionality. So for us, there is a trigger that means if somebody does not have known, no, let me rephrase that. If somebody has CKD3 already, and their repeat EGFR and ACR is within the same range, yeah, that will not flag up to say something that requires action. So they've not got worse, they've not got better. Technically, CKD doesn't get better, but EGFRs get better because it's an estimated glomerular filtration rate and not a true glomerular filtration or all that kind of jazz. But technically, if you're in that same bracket, it does not. But if you're dropping it into the first one, when you're processing it, it flags to say this person appears to have a new CKD group. Have a look at the notes. Now, depending on what you're doing for that particular patient, you may choose at that time, actually, I'm not got the time, I'm doing the results, appointment, book with GP, A&P to go through these results, or you may look at it and think, actually, that's quite a significant drop in somebody, and we need actioning straight away, that kind of thing. So we don't automatically code it if they don't belong in that group. But all the GPs have a QI session where we go through different aspects of it, and you pick them up every month to say, these are the results that are flagged up in the last month. Have we missed anything? The other ones is people who transferred from different practices, who have had historic EGFRs or ACRs that may or may not have been coded, and we look through that. So I'm giving you a really long-winded response, aren't I? So the short answer is, I think, if they're consistent in the same group, and they're groups 3, 4, or 5, we don't flag it. But obviously in G1 and G2, you can only code them as CKD if they have evidence of kidney damage. Significant proteinuria is one of them, or if they've had a reversible glomerulonephritis that's been treated, technically the nephrology will tell you if there is a diagnosis or not. Have I convinced you? Brilliant. Brilliant.
Thank you very much. Jez, did you want to come in?
Yeah, just one top tip really.
KFRE?
Thanks for that, really good. One top tip is that the renal team are really keen to know about these patients where you have a worry or you're not quite sure how to interpret the trajectories of these things. So it's a really good use of the advice and guidance portal, and you get a little payment for that if you use that under the current contract. So renal advice and guidance, they can look at all the results on ICE that you've got. You can explain what the issue is, and that's well worth doing. Yeah. And the other thing is, I think you did emphasise this really, is that the KFRE is really useful. KFRE is this calculation that helps you, if you've not come across it, we're starting to get it through ICE. It's a bit hit and miss. Yeah. You may well have to calculate it manually or use other ways of doing that. There is an emphasis on doing that, but there is still an importance on categorising, and using the traditional renal categories is still quite helpful. So there are two sort of ways of measuring the trajectory for patients, and I think whilst we're working at the moment, it's probably worthwhile doing both.
And whilst Jez hasn't mentioned it, you may have seen that Jez actually created a KFRE calculator that's now available on System 1. And is it EMIS as well, Jez?
Yeah, but that
Yeah.
involves a sales pitch, which I'm not going to do.
Okay, no, you're not, but I will. So yeah, click that button and that'll actually go through the metrics and support you to get the KFRE done. The only problem with the KFRE that comes back from the trust is that it's not read-coded, so you can't search and pick up how many patients have a KFRE score that's over 5% based on what the hospital sends you. The only way to get around that is when the result comes through, you have to manually go and code KFRE. These aren't things that we should really be focusing on. There should really be a solution within System 1 and EMIS to automatically do it. In the absence of that, those of us with an interest in this kind of stuff build our own things to make it work, and they do work. So.
Thank you so much. I'm afraid we are out of time.
Brilliant.
And I'm conscious of our next...